Hi, in this video I'm going to go over questions that were submitted during the Corazon Institute Hormone Disorders course that I wasn't able to answer during the course itself. Okay, so let's go through some of the questions here. In the studies you reviewed that show long-term benefits to using HRT, were the hormones synthetic? Is there a difference when using the bioidentical long-term? So most of the studies that have been done long-term with HRT therapy have been the ones that are synthetic. There are some very small bioidentical studies with it, but when you really look at the big trials, they've all been using the synthetic hormones, not bioidentical. My understanding is that the first pass for the liver from taking oral estrogen increases the risk of clots and increased inflammation. Yeah, I mean, estrogens, whether they're bioidentical or synthetic, do have a risk on clotting factors in combination with other variables. So estrogen doesn't always mean that you're going to have increased clotting. And one of the things you can always do is measure serum fibrinogen levels and prothrombin time if there's any considered risk for that, whether it's bioidentical or synthetic. Okay, next question. I've noticed that men on insulin have higher levels of sex hormone binding globulin. Despite robust total testosterone, their free levels are lower. Why would using insulin make the sex hormone binding globulin go up? Yes, there's a list of things that make sex hormone binding globulin go up. Like insulin can go up, but obesity can make sex hormone binding globulin levels go down. Liver diseases can impact things one way or the other. So, the binding hormone levels, the sex hormone binding globulin, aren't the only factor why hormones will be free or protein bound. There's also albumin and other proteins that also bind to testosterone. So the question here is, despite robust total testosterone, the free testosterons are lower. Yeah, this could maybe be part of the binding globulin issue. I don't know if it's directly related to insulin, but in any case, the key thing would be if they are taking insulin, and if you suspect this, if you can improve their insulin resistance so they can reduce their total insulin intake to see if that has some impact. But at some point, some of these men may do better if they actually take testosterone to improve their free testosterone levels, because it may also have a significant impact on their insulin resistance pathways as well. Okay, next question. Regarding vasomotor symptoms like hot flashes, what happens when the symptoms stop? So once the symptoms stop, that basically means the fluctuations of estradiol estrogens are no longer happening. Why do some women experience the symptoms many years later? Is there recurrence of estrogen spikes? It's possible that they could have recurrence of estrogen spikes. Typically, though, it's not a common thing. Typically, once a woman goes through that transition, it's there. If someone is having these so-called spikes, hot flash spikes again, I probably think that it's more likely like Hashimoto's that are causing some of those spikes from autoimmunity later, but it may not be related to estrogen spikes with menopause if it's many, many years later. Anytime you have anyone that has estrogenic symptoms that are spiking up and down post-menopause, you also always have to be worried about estrogen-producing tumors. So there's estrogen-producing tumors in the gastrointestinal system and throughout various tissues, and you can also have ovarian malignancies that can spike estrogens. So it really would require a workup to make sure there's no red flags if the woman is having reoccurrence of hot flashes years later after menopause. What are your thoughts about the Wiley protocol? I have no idea. I don't read other practitioners' protocols. I think I really don't think a protocol is an efficient way to do things, and that's why functional medicine is really about individualized, personalized medicine, not really about any kind of protocol. So any kind of protocols are just based on some theory that can be generalizable to the population. It's not individualized, personalized, evidence-based medicine that's focused on the individual itself. It's a generalizable protocol that someone has come up with. So the goal of functional medicine is to really evaluate the patient for all the independent variables that they have uniquely and then try to do those interventions together. So you typically won't see most functional medicine people really excited about lots of different protocols. Now, sometimes you can have general concepts and principles that may be termed protocol to to impact some commonly known pathways or certain conditions. But I'm not familiar with the Bradley protocol. It seems the abundance of HRT research is geared towards synthetic hormones in women, which equals a higher significant risk of clots and strokes. Because there's not a lot of great research that shows that bioidentical is much, much safer. So just know that. Because drops in estradiol increase inflammation dramatically, isn't there a benefit to keeping healthy levels of estrogen post-menopause? Yes, there's definitely benefit to keeping estrogen levels stable post-menopause. That was really the goal of me trying to share the major research papers of perimenopausal transition. What delivery method and type of estradiol replacement do you feel is the safest? Well, I think when you look at replacements, I think the topical creams and lotions have the greatest tendency to cause buildup in tissue and throw off hormones later. So that's one of the concerns with topical types of hormones. Oral hormones have the potential to be metabolized through the hepatic pathways into other hormones, and that may not be as efficient, but still very effective and useful. Injections would always be the most effective replacement method, because you're getting it right into the bloodstream at that. You're not getting it through body fat and rubbing it in. You're not taking it orally to have it go through the hepatic liver pathway. So, injections would always be the most effective way. It's commonly used with men with testosterone replacement, but it's not typically used with women. But I think that would be the most effective way. But all of them will have some effect on a patient, and sometimes patients need to experiment with different types to see what works best for them. In the senescence-induced estrogen receptor degeneration dysfunctional uniform across all body tissues? Yes. So with senescence, when they look at receptors, they typically find defects in hormone receptors all throughout the body. If it's related to senescence impacts all cells in the body, not just one cells. You could have greater degree of loss in certain tissues earlier than other tissues, but ultimately, the pathophysiology of geroscience, where you have senescent loss of receptors, will have an impact systemically, not just on one tissue specifically. And then, the second part of the question: would the decline in receptor function due to senescence be the same in the brain as in the pituitary ovarian system of the HPA axis? So again, it could be varying degrees of loss of function. We know that if it's a senescent model, it's going to be systemic, but it's hard to say if the pituitary ovarian system is going to be impacted more than the HPA axis and so forth, and which receptors. We just know a phenomena that happens as we have accelerated aging phenomenon is that not only do the glands become inefficient as making as much hormones, but the receptor sites themselves become less efficient over time as the cellular pathways go through aging changes. Okay. Does taking oral bile acids like TUDCA inhibit proper liver gallbladder breakdown, detox the excretion of hormones and their byproducts? So this is like a bile salt. So basically, TUDCA is bile salt. So bile acids, these bile acids and bile salts don't really inhibit your proper liver gallbladder breakdown. They're just there to basically have the functions of helping with digestion. So I don't think you're gonna have like a loss of function if a person's using it for a period of time. If someone's been using any kind of digestive enzyme or digestive support for a long period of time and they stop taking it, they may notice it takes a few days for their system to adapt and function again. But most people that take oral bile acids and bile salts usually take it for a short period of time, get their gallbladder functioning well, and then when they go off it, there's no loss of feedback loop function or deterioration. Okay. You mentioned problems with keeping estrogen and HRT high for too long. Yes. What do you define as too high and too long? And would this be mitigated by a compliant patient who does all the other recommended exercise lifestyle interventions? So, there's going to definitely be some patients that have a tendency or a sensitivity genetically to some estrogen-related tumors and cancers, most common being breast cancer. So for them, even levels that maybe even the high normal may be a risk factor for them. And other people that don't have that estrogen receptor cancer genetic sensitivity may not have the same issues, even if their hormone levels are very, very, very high. So we don't really know what the lab level for high is. The that relates to condition and disease. And this is kind of the problem with the whole field of hormone replacement therapy, is we have some general ideas from lab tests what numbers are. If they're significantly above the lab range, that may potentially be an issue for some people, especially those with estrogen sensitivity conditions. But there's people that have really high levels of hormones for many years and really have no noticeable proliferation or concerns with it, and maybe offer some protection. So it is hard to do. I couldn't give you the definition of what's too high or for too long. It's something that it really is a clinical guess, a clinical assumption. You can always use the lab range to give you some general ideas. If it's like 10 times the lab range for many years, you'd definitely be concerned. So the answer really is we don't really have an exact criteria or standard for length of how long and what is really considered too high outside the basic lab range. Any comments on gender dysphoria? It's not related to hormone imbalances. It's you don't see someone who has high estrogens or high testosterone or shifts in hormones having clinical presentation of gender dysmorphia. So I think it's not related to hormone levels. Okay, next question. What is your opinion about a comment on one of these slides? Oh yeah. Okay, so this was from a systematic review that was done on hormone replacement therapy, and they quoted in there's no high quality consistent evidence that black cohosh botanical products, omega-3 fatty acid supplements, or lifestyle modification alleviate hot flashes. It's true, there isn't. There just isn't long-term clinical trials on this. There are studies on it, and it does have a level of rating. I think the rating was like a C rating, and a B rating for not actually having them, like in double negative, not having these patterns. But there are studies on these supplements having some impact, and for the most part, we don't see any safety issues and safety concerns with someone using fish oils, for example, to control their hot flashes, and even things like black cohosh. But it is what it is. So that systematic review that was presented in the introduction part of the seminar, if you get a chance to read the paper, it does an excellent review of what the evidence currently is and ranks the research quality very well. Would the hormonal system have manifestations from physical trauma like what football players or car accidents? What about emotional traumas like PTSD or child abuse? Yeah, I mean, of course, the endocrine system is really controlled by the neuroendocrine system, and really the neuroendocrine system is really part of the neuroendocrine immune system, and the neuroendocrine immune system is absolutely impacted by things like trauma, whether it's emotional trauma or physical trauma. We know there are studies that show puberty can be delayed, or you can have early onset of puberty changes with PTSD, with child abuse. And we know that like PTSD patterns can definitely cause ongoing stress responses, and we know that stress responses can impact FSH and LH. So, I mean, these things are all possible, but it's not linear, meaning if A equals B, so not every person that has had emotional trauma or PTSD is going to have that be the cause of their hormone imbalances. But I'm sure for some people that would be a very powerful mechanism. And again, that's the uniqueness of individual personalized medicine. Okay, in autoimmune patients, who demonstrates loss of tolerance? Let me read this again. In autoimmune patients who demonstrate loss of tolerance, should they be reluctant to add HRT even bioidentical creams as just one more foreign antigen to possibly activate their immune system? No, I don't especially see that to be an issue. For patients that have autoimmunity and they actually have hormone deficiencies, sometimes when their hormone insufficiencies are addressed, they may actually have the ability to recover, really support their immune system, and improve their tolerance. So it doesn't mean anyone that takes HRT is going to have that benefit, but for sure, if they are actually deficient, you may see some significant change in their function and outcomes. Like thyroid hormones, for sure, is going to profoundly impact tolerance. And you can have varying degrees of impacts but estrogens in females and testosterone in males with improving immune function and tolerance if they were low and were able to restore it. If they were normal levels and you added more, it doesn't seem like you have any major clinical outcomes with that. Okay, next question. What advice would you give to the thyroidectomy patient or hysterectomy patient in terms of how they should mitigate an accelerated decline in their physiological resilience and subsequent expected acceleration of hormone dysfunction? My advice would be if you had your thyroid taken out and your TSH is high, you should be on replacement. If not, you're going to have accelerated brain neurodegeneration. You're going to have accelerated bone composition, degradation, osteoporosis. You're going to have tendency to get gallstones. You know, really hard time with your metabolic rate and energy and just general cellular functions. So once a gland is taken out, and with hysterectomy, I'm assuming it's a complete hysterectomy or oophorectomy where the ovaries are taken out, it may be very important to be on replacement to mitigate some of those decline patterns. Now, you know, there's some patients that have those procedures done and they just don't want to take them. I think they're going to have some accelerated aging and risk of deterioration in a negative way if they don't get that addressed. Are the 5 to 10 gallons of bottled water safe to use in point-of-use dispensers if manufacturers claim they're BPA-free? They're going to have plastics in them. Those big plastic bottles, anything you say BPA-free is really plastic, and if it's plastic, it has BPA in there. So, you know, sometimes we all have to use some things like that, but the key is if you have to use anything like that for a short period of time, you just want to use it for transport. You definitely don't want to keep it in a place that's hot. Heat can definitely displace more BPA into the water, but it all depends on the total load. I think it's going to be very, very hard to be completely free of being exposed to BPA. You just want to limit it as much as you can. But those big 5 to 10 bottled waters, they're going to have, you know, BPS or BPF instead of BPA, and they'll claim that it's BPA free, but those still are endocrine disruptors. It's going to impact some people more than others, obviously. Okay. Next question, part 2. Does it make sense to get water from a place that provides reverse osmosis water if we have to bring the water home in a large plastic jug? What you really want to do in your home is make sure you have a really good filter. So however you're getting your water source, by the time you get it through glass, you have a filter. And it could be like a Berkey filter you put your stuff through at your home, which you can, you know, put on a countertop. It could be water, it could be your home water system like we talked about in the course. You definitely want to have a water filtering system to get rid of as much of the contaminants like BPA as possible. Can you please comment on ways to stabilize blood glucose besides diet modifications? Well, we have an entire course on this, and ultimately when people have unstable blood sugar levels, the question you're asking is the blood sugar instability primary to what their diet is, and then you start with diet. And if their diet's perfect and they still have blood sugar issues like hypoglycemia or insulin resistance patterns, then you have to go down what things could be driving the adrenals. And things that could be driving the adrenals could be, you know, infections, any kind of immune pattern. It could be overtraining patterns. It could be lack of sleep. So, you know, it could be undiagnosed flare-up, like ongoing celiac disease. So it really could be anything that's driving stress to the system. So it's always a red flag if a person has a blood sugar issue, but their diet doesn't justify why they have their insulin resistance or their hypoglycemia. Next question. Can intermittent fasting cause reactive hypoglycemia that affects sleep? Absolutely. There are definitely people who do not have the physiological fitness to do intermittent fasting. So typically people that are underweight and have already have low adrenal gland function, like if you measure their cortisol levels are low and have low blood pressure, that low blood pressure, cold hands, cold feet, low blood sugar being glucose below 85, like that patient may not be able to handle intermittent fasting. And many times they're also underweight patients with, and they won't be able to handle this intermittent fasting. And if they have their glycogen levels drop because they don't have enough buildup of glycogen throughout the day. They'll definitely wake up and have sleep issues. Next question. The patient is on HRT cream for estrogen, testosterone, but takes oral progesterone before bed because reportedly metabolized into GABA to improve sleep. Any insights of the possibility of this? Well, progesterone's not going to be. Progesterone's never going to be metabolized to GABA. They're completely different biochemical structures, totally different. But progesterone can have an impact on sensitizing GABA receptors, the so-called homotropic modulation. So yeah, that might be a good idea, a good strategy for someone. For some people, doing that can improve their GABA activity, which then helps them sleep. So I think any insights to the plausibility of this? It's for sure plausible that progesterone makes GABA receptors more sensitized and can impact sleep, for sure. But it's not really it being metabolized into it. Okay, next question. How long after a meal will the insulin spike cause tiredness in an insulin-resistant patient? It varies. It just really depends on each patient. But the typical response is if someone has insulin-resistant spikes after a meal and they get tired, the first thing is there's going to be a variance of how long after they eat. For some people, it'll be like within 10 minutes. For other people, it could be 30 or 40 minutes, and then they'll start to get really tired. And for some people, it can last for 3 or 4 hours. And for other people, it could just be like a 20-minute thing and they get over it. The greater degree of insulin resistance they have, the longer the pattern will last. So if they have pretty bad insulin resistance, they'll eat a meal and they may be really tired and crave sugar and not be functioning for like a couple hours, and they'll have to have coffee or stimulant to try to get out of that rut. That's a sign that they have pretty significant insulin resistance. People that have better resiliency, they may get a little bit tired after they eat, but within 10-15 minutes they're back and functioning as if they were before the meal. Okay. How do you increase glycogen reserves? Eat throughout the day. The only way you can increase glycogen is to make sure you have plenty of calories and glucose supply to help store glucose as glycogen throughout the day. So most people will have enough glycogen reserves if they're eating normally and getting their sufficient amount of calories. The only time you'll have people that will not have enough glycogen reserves will be if they're on a caloric restriction, maybe for weight loss reasons, and they may have a tendency to wake up in the middle of the night, or for people who are stuck in this physiological stress pattern, burning up all their glycogen reserves, or something really driving their adrenals. But the best way to raise glycogen reserves is basically to have enough calories and to make sure that there's enough protein, carbohydrates, and mostly good quality sources of healthy foods that can be converted into glucose and then eventually into glycogen. You don't want to use simple sugars to build glycogen reserves, like candy or juice. Please explain again why hypoglycemia also has an insulin spike. Yeah, so when blood sugar levels drop, there's no glucose available to get in for the cell. There is an attempt to get glucose into the cell by having a surge of insulin. So the job of insulin is to get glucose in. So normally if glucose is high in the blood, there's a signal to get insulin into the cell. But if the cell itself also starts to get hypoglycemic, it tries to get any available glucose into the cell, so there could be a little bit of an insulin spike when that happens. And when does the spike occur relative to hypoglycemia? It's going to be when the cellular glucose levels are low, but that's going to be hard to know clinically. What can we do to restore cholesterol levels in those who are naturally low for those on statins whose providers likes low cholesterol levels? Okay, well, if someone's naturally low and their endocrine and they've always had a low level of cholesterol, but their endocrine panels are normal, there's nothing to worry about. What you're worried about is for those people that normally had a cholesterol of like 190 or something like that, and 200 or 220 or something, and then now they're down to like 110, 120. That could happen sometimes when there's pathology. Even certain malignancies and cancers can really deplete cholesterol like that, or it can happen from taking statins. For some people, when their cholesterol levels drop below 150, for sure below 100, you start to see on their steroid hormone pathways that their hormones downstream will also start to be impacted by that. There are some cardiologists that believe people's cholesterol levels should be less than 100. So there's a point where there could be different models that different practitioners have with managing the patient, and then ultimately you have to patient has to decide which practitioners they want to see for what their health concerns are. But that's just healthcare. Just know that those mechanisms take place, educate your patient, and then let them decide what they want to do about that. How common is it for men using testosterone to not be able to recover hormone balance after ceasing TRT? If men just go on testosterone, it really depends on how long they've been on it and what kind of steroids what kind of testosterone they're taking. If they're taking like anabolic synthetic steroids to gain muscle mass, those are very aggressive. And if men were just taking testosterone by itself, they may have a hard time recovering. If they've been on it for high doses for a period of time, like they're taking 400 units of testosterone a week or higher, even higher than 300. Those are pretty high levels. For some people, that they can respond very quickly. Concern with men using testosterone is that they get infertility. So this is why they use HCG injections while they're giving testosterone every week to prevent that from happening. And if they have been on testosterone and want to get off it, sometimes just when they go off testosterone, if they can stay on or go on HCG for a month or two, they can usually recover their feedback loop. If they're not recovering their feedback loop because of that, and then obviously inflammation and things that impact the Leydig cells could be a factor. So you can definitely look at their hormone levels once they've been off testosterone for a period of time. If they've been off testosterone for a period of time and their testosterone is low, is not able to recover from that, you immediately want to look at the LH. If the LH is low, then they have like this pituitary suppression, and this is where HCG will shine. 1 or 2 months of that can make a huge difference. Or even some of the botanicals we talked about that can impact testosterone, like tribulus and fenugreek, can be something to consider for that. If their LH is high and their testosterone is low, that's like a lytic cell dysfunction, and that's where you really want to look at inflammatory pathways. Okay. Regarding the biotransformation of hormones in the gut, you discussed the elevated beta-glucuronidases. Does low beta-glucuronidase impair the biotransformation of hormone toxins in the gut? How does one raise or improve a low beta-glucuronidase? So, we don't really know about any significant patterns of beta-glucuronidase being too low causing an issue. Gut microbiome modulation of hormones tend to be very efficient in what they do. It's just when we have dysbiosis, we get this greater upregulation of this activity. I really haven't read much about anything related with lower activities, so I can't really comment on that. And there's lots of different enzymes that gut bacteria have. They're having all these functions beyond what we know and understand at this point. But ultimately, there are some principles we know about. We do know that if there's high amounts of diverse bacteria in the gut, that you have greater potential to modulate for hormonal shifts and metabolic shifts. And people tend to be healthier when they have greater microbiome diversity, since each of these bacteria contain different enzymes to help maintain homeostasis of hormones or other metabolites when things are off. But I'm not sure what the low levels are or what you can do for that. It would just say encourage a healthy, diverse microbiome. Is there a concern about long-term use of berberine disrupting the gut microbiome? No, I don't really feel that's an issue whatsoever. I'm not concerned with that. So I think that's not a concern. If anything, berberine may have a beneficial effect on G-coupled proteins in the gut, modulating immune function. So I think there is some misinterpretation of information on berberine being an issue for the gut microbiome. Next question. Concerning peptides, You did not mention caspepsin 1. I often get questions about peptides, and this one in particular in lieu of hormone replacement therapy. What are your thoughts? It's a gonadotropic releasing hormone stimulant. There's so much research in a lot of these peptides. The one with the most research is sermorelin, but it's reported to impact growth hormone levels and has a significant impact on growth hormone levels and also with libido. So, if someone wants to jump in the world of peptides, there is some level of, taking a treatment that doesn't have a lot of research to support it, and certainly no long-term clinical trials. But it is something that many people do use to jumpstart libido and low growth hormone functions. Okay, and then the second part of the question is, also, since many clients are taking ashwagandha for sleep, is there a concern about affecting testosterone levels that it does in men? No, I've not seen that. And I don't know of any papers related to that. Okay, next question. If a woman in their late 20s, let me go back to this ashwagandha question. For some people, it might, and there's in real clinical settings, sometimes we suspect something, and if we suspect something, do we have to do trial and error and see if it makes a difference? Because we don't know every single mechanism, and not every single study has been done, and we haven't read every single study that's out there as clinicians and practitioners. So, if you suspect a person's ashwagandha may be impacting sleep, or they're suspecting their testosterone levels or something, or any variable maybe in that, sometimes you have to, the only thing you can really do is trial error and remove that intervention and see if it makes any difference, and then reintroduce it and see if symptoms come back. Okay. If a woman in their late 20s to late 30s wants to have successful conception, are there any negatives of her taking advantage of higher fertility days after just ending birth control pill after many years versus working on a healthier hormone profile before conceiving? This is a general question. I mean, when we did an entire course on fertility where we went step by step by step for every single thing that you need to work through. The ultimate way I can answer this question is just get your person healthy first. Don't try to jump into any kind of fertility, jump into conception if they're not healthy. So, I would really encourage you to check out that fertility course. We talk about all the things about preconception risk and all the variables and factors that are in that, and we spent a lot of time on that. There's a lot of variables you want to consider with that. Okay, next question. What are the more advanced gold standard tests for male and female fertility available today for those wishing to screen for all kinds of potential disease probabilities if they're debating whether to conceive or to adopt a child? Well, I think the fertility testing today is pretty good. The male sperm testing is very effective, and the anti-Mullerian hormone and looking at the ultrasound for the follicle count they're pretty good. They're pretty reliable. I think there are pretty good tests available today. So for females, it's going to be the AMH test and a ovarian ultrasound to look at the follicles and get a follicle count. And then for men, just a good old basic semen analysis. They can look at the health of the sperm, motility, and quantity. Will be very, very good ways. So you want to do the male factor and female factor screenings for those. We talk about that again in a lot of detail. Just go over the research and the fertility course of the Crosby Institute. Next question. What are the most effective binders during moderate to significant weight reduction that will get chemicals waste stored in the body fats out of the body? Well, typically, one of the best binders always is going to be fiber. So a person that is exposed to chemicals or having weight reduction, and some of the chemicals are being released from body fat into their system, fiber is always going to be something to consider as a binder, but also just supporting phase 1, phase 2 detoxification pathways, phase 1 and phase 2 pathways, and acetylcysteine, B vitamins, milk thistle, the typical phase 1, phase 2 support compounds, glutathione. Those can be things to consider. Okay. Outside the rhythm method, which birth control methods do you think are the best and worst, and why? Well, the best method is abstinence, of course. Rhythm method is, I don't really have an opinion on this. Like, I'm not. This is not my. This was really one of the focus of the course. What are the best control methods? I mean, obviously you can look them up. When you look at things like barriers like condoms and those types of fertility, there's a percentage of fertility risk and so forth. So, let's move on. What are the long-term effects of yo-yo dieting that has been happening for years? I have no idea. Are there any emerging approaches to the improvement of post-finasteride and post-SSRI sexual dysfunction and its related syndromes such as hair loss? I'm not aware of any. This isn't something I've had to deal with the patient population for me to go and do a lot of research and analysis on that, and I don't have any specific clinical experience on this question, so I really don't have an answer for that. Okay. Well, thank you for those that submitted this for part 1 of the course, and we'll link another video for part 2 as well. Thank you.